Hello. Hi, everyone. All right, good afternoon. Welcome to our Rising Star Seminar Series in May. Thanks for coming. It's 3 o'clock, so I'm going to start now. First of all, I would like to acknowledge the traditional owners and custodians of the lands on which we are meeting today, the lands of the Gadigal people of the Eora Nation. I would also like to acknowledge the lands on which our online attendees are joining from today. We pay our respect to all elders past, present, and emerging. Before I introduce our first speaker, I'd like to give a quick introduction to the CVRN. The CVRN was established in 2005 to strengthen, facilitate, and promote cardiovascular research in New South Wales through collaboration. We do this by developing and supporting strategic events and opportunities to enhance research capability with particular focus on, particular focus on early and mid-career researchers. Currently, all major research institutes and universities are member organizations of the CVRN, and this includes all New South Wales local health districts. The CVRN has over 600 individual members across research spectrum, from basic to public health researchers, investigating all aspects of cardiovascular diseases, including stroke, diabetes, and kidney disease. The CVRN is funded by New South Wales Health and Organisation membership fees and hosted and supported by the Heart Foundation. We have an executive committee that drives the strategic direction and the Rising Stars subcommittee responsible for developing and driving events and opportunities for early and mid-career researchers. The committee is co-chaired by Dr. Alice Gibson, who's here today, and Professor Jamie Van Berg. Our seminar today is on the topic of innovations in metabolic health, dietary patterns, clinical decisions, and population insights. Due to unexpected circumstances, we only have 3 speakers presenting today, but I'm sure they will give fantastic presentation. So each of them will present for about 10 minutes and then followed by Q&A for about 5 minutes. You're welcome to ask questions by raising your hand or posting in the webinar Q&A functions. Yeah, Dr. Mitchell Sarkies. Dr. Mitchell Sarkies is a senior lecturer and NHMRC Emerging Leadership Fellow at the Sydney School of Health Sciences. He holds a prestigious Horizon Fellowship that is establishing an implementation laboratory. He co-leads the Sydney Health Partners Implementation Science Academy, which supports advancements in the science of implementation in health. Dr. Sarkies has a clinical background in physiotherapy and is interested in large-scale implementation projects that rapidly translate health and medical research innovations into better health outcomes. His research aims to support translation of clinical practice guidelines into routine care, introduce large-scale policy change, and reduce unwarranted variation in care. Also, we welcome his research assistant, Mr. Emile Belramoul. So he holds a Bachelor of Biomedical Science and completed his honors in health science, focusing on familial hypercholesterolemia and acute coronary syndrome. He's currently working as a research assistant in Dr. Mitchell Sarkies' team. Let's welcome them. Thank you.
Thank you. That was a very kind introduction. Is there a clicker or do we just do it here? That's okay. I can just do it on the laptop. So we're going to be talking about a project that Emile actually undertook as part of his honours project. And then we've managed to keep him in the research world and keep him in the team as a research assistant. Maybe we'll convince him to do a PhD. So this project focused on the prevalence and prognosis of familial hypercholesterolemia after acute coronary syndrome. and this was using a registry data across Australia. Oh, there's our introductory slide. So before we jump into the specifics, I thought I'd just take a step back and run through a couple of definitions, because not everybody's familiar with this condition, familial hypercholesterolemia. I'm going to use the acronym FH from now on because it's hard to pronounce. So hopefully we all know about low-density lipoprotein cholesterol. So this is a ferry molecule for cholesterol, and it is kind of one of the primary causes of atherosclerosis, so a bad cholesterol. Familial hypercholesterolemia is a genetic condition which causes high LDL levels for people from birth. So it's not something that emerges later in life. It sort of starts to become apparent as early as age 2 for some kids. And it significantly increases your risk of premature coronary heart disease. I'm just going to move this bit off the screen here. And acute coronary syndrome is, I guess, kind of the downstream impact of this atherosclerosis and coronary heart disease. It's a result of multiple clinical conditions, but basically results in reduced blood flow to the heart. So, a heart attack or something like that, bringing you to hospital. So a little bit of an introduction to FH itself. So it's a very common genetic condition, so 1 in 300 approximately. And as I mentioned before, it's associated with cardiovascular disease. It's very underdiagnosed. So in Australia and internationally, less than 10% of people who have this condition have actually been diagnosed or detected with it. And then a small fraction of that 10% is actually being treated to target. So it's a really big gap in clinical practice. Genetic screening enables us to identify people early in their life with this condition. So the idea is you diagnose people when they're really young, get them on treatment early, so you can start statins from age sort of around 8 or 10, so very early in life, and that actually reduces their risk of ACS down the track. So this is diagnosed phenotypically. So what you see clinically is people get kind of like deposits in their tendons. So you can see the images there, and you also can get these deposits around your eyes as well. Now, there's a conspiracy theory that the Mona Lisa actually had FH, because people have identified these clinical markings actually in the Mona Lisa. So there you go. So you might have had FH. And just to kind of bring home the importance of this condition, this is a cross-section of an artery from a healthy patient. And this is a cross-section of an artery from a patient, even only 24 years old, with homozygous FH, who died suddenly. So you can see that, even at age 24, you've already got this atherosclerosis building up and possible blockages. So our theory was that if people attending hospital with ACS, is that this would be a population that would be more likely or have a higher prevalence of FH than the general population. So we thought this is a really good population for screening for FH. And so we wanted to get an idea about whether we could work out in a database of people after ACS whether in fact they had FH. So that was our main aim, and we wanted to use the data registry for analysis. We also wanted to look at the prognosis for people after ACS, whether or not they were FH or potentially FH positive or potentially FH negative. So do people with FH after a heart attack do worse than people without FH? And related to that, whether they were treated aggressively enough with lipid-lowering therapy after their event. And then finally, we also wanted to do an exploratory analysis to have a look at whether there was any differences in cardiac rehab and FH outcomes between those groups. Interestingly, though, because such a small number of patients actually go to cardiac rehab, we weren't really able to tease that out in this project, unfortunately. And so the study design was assessing ACS patients specifically with cholesterol levels recorded. So the database that we used, only about half of the patients in the database had a recorded LDL cholesterol. So that was kind of our starting point for identifying people who might have FH. And then we also excluded patients that didn't have other kind of essential clinical data. So people who, for whatever reason, they weren't able to follow up their data collection. And we used the concordance registry. So this is a registry set up by David Brieger. So just want to acknowledge the amazing work they've done to build this registry over time. It has about 12,000 participants across 32 hospitals across Australia. So as I mentioned earlier, we got data for about 6,000 of those. And our criteria for diagnosing FH, so there is a clinical criteria called the Dutch Lipid Network Score, which kind of categorizes people as whether they're unlikely to have FH, possible FH, or probable/definite FH. And there's a whole bunch of clinical assessments you can do to categorize them according to that. But unfortunately, we were limited to what was in the registry itself. So we just used like a modified version of this score. So we used LDL cholesterol levels and the age of their first cardiac event onset. So if anything, we potentially are underestimating the prevalence of FH in this group rather than overestimating. Finally, I think our outcomes were mostly on major adverse cardiac events post-ACS. And so we also included cardiac-related mortality in that. So this is a combination measure of all of these events post-ACS plus those people who died for cardiac-related reasons. And the outcomes themselves in the registry were adjudicated by clinicians. So we're pretty confident in their accuracy. And all the fun stuff, statistical analysis. So we wanted to look at, some demographic patient characteristics related between the two groups, whether they had FH or not. We also wanted to look at cholesterol levels and age over time, and we used a multi-level regression analysis for that MACE follow-up. I'm going to pass to Emile to take us through the results and what he found.
All right, thank you, Midge. So I'm just going to talk through the results and what we actually found from this study. So first of all, I'd like to bring your attention to the percentage of probable or definite FH. Now, usually in similar studies in other countries, we've found that around 1.5% of these cohorts, of ACS cohorts, have FH. We're finding significantly higher numbers in our cohort. So that is quite a bit more than previous literature would indicate. Unsurprisingly, FH patients tend to have or be ACS patients much earlier in life. They start collecting this atherosclerosis much earlier in life. So naturally, we see them have these cardiac events earlier in life too. So that wasn't very surprising. But what was striking was the proportion of Indigenous peoples in our population. We had over a quarter of our probable or definite FH patients being of Indigenous heritage. This is something we're currently investigating because this was quite a worrying finding. Now, just to look at some comorbidities. So we found that FH patients and their families were just much more likely to suffer some cardiovascular events, which is quite natural. It's a genetic condition. You expect this to flow through families. So this wasn't particularly surprising. And individuals with FH were much more likely to experience cardiac events, that being hypertension or any form of or having previous MI in their lives. And this is a surprising finding that diabetes was also quite common in FH patients, in probable definite FH patients. But that's because our criteria really does sort of encompass individuals with metabolic syndrome, people that are overweight and tend to accumulate more cholesterol in life. So this, while it was very significant, that can explain some of that. Now, just to look at some major adverse cardiac events at the 6 months follow-up. So what we found is, firstly, the incidence rate, even after their follow-up, was much higher in the probable definite FH group. So these are people that definitely do have these events much more commonly than people who don't have FH. And as you can see, when we did an odds ratio where we tried to find the odds or the likelihood that these patients would have FH, we can see people in the possible FH group being having an odds ratio of 1.41. That essentially means they have a 41% more likelihood to have a cardiac event. And our probable definite FH group in that unadjusted odds ratio had a 52% more likelihood to have FH. And as we continued to make adjustments in our models, so for age and sex adjustments, as well as model 1, which we adjusted for smoking status, hypertension, and whether they had diabetes, and model 2, including statins at 6 months, and then finally model 3, where we also looked at attendance to cardiac rehabilitation, as well as being prescribed statins at discharge. Again, it just kept getting much more likely. In fact, it became so likely that they'll more than double the odds that they would have a major adverse cardiac event 6 months after being admitted into hospital after their first heart attack was more than double being an FH patient. So this is definitely an at-risk cohort. Now, why does this matter and what are we going to do next about it? So like we mentioned earlier, there appears to be a greater proportion of people in Australia with FH than other countries, according to other literature. And as we mentioned earlier, looking back at that coronary artery with that 24-year-old who dropped dead, it's so important to start our early intervention early. It's about really trying to increase our genetic testing, trying to find them more commonly and get them on statins or any form of medication that helps them as soon as possible. And especially with that Indigenous population, that about 28% of our probable definite FH cohort were Indigenous. That was quite striking to us. So we're currently in contact with a cardiologist that works out of the Aboriginal Medical Services to see if we can make if we can start helping in that area. Now, unfortunately, our study, as all, comes with limitations. So firstly, we could not genetically confirm these patients. So these are all phenotypic diagnoses. So we looked at the likelihood they have FH. So even our probable definite group, it's a very likely to have FH, but it's certainly not guaranteed. So we really lacked that genetic testing, and that limits our diagnostic position a little bit. Now, our selection bias, as Mitch mentioned earlier, we have over 12,000 patients in our cohort, but almost half of them we had to remove because we just didn't have enough data on them. And so this may not be perfectly representative, but we're quite confident in what we've found with what the data we have. And finally, we are using registry data. This comes with its own constraints. We have missing data sometimes. We had a 160-year-old, unlikely to be the case. So it just naturally comes with its problems. But like we said, these are clinically adjudicated by clinicians, and so we're quite confident in a lot of this research. Right? And just a thank you to all the other authors on our paper, Dr. Karashuan, Dr. Matthew Hollings, Dr. Karen Birkenhead, and Dr. David Brieger, all played a significant part in helping this study come to fruition. All right. Thank you, and time for questions.
Any questions from the audience?
I was just asking why you think the proportion is higher. Do you think it could be related to the selection bias, or is it possibly because the Indigenous population is overrepresented in the sample, or is it because the people with the LDL recorded are more likely to have it?
Just see if this is working. We think in an ACS cohort, you're likely to have a higher proportion of people with FH than the general population because FH causes ACS, more or less. So you're much more likely to earlier in your life have a heart attack if you've got untreated FH. So the theory being that therefore there's a much greater population there. And I think last time I checked, it can be as high as 1 in 20 in those populations. So really overrepresented. And part of the motivation for doing this work is if we could screen people after they've had their first heart attack for FH, because it's a genetic condition and your first degree relatives have a 50% chance of inheriting it, you can then cascade test those people's children and grandchildren to try and catch them earlier in life, get them treated, and hopefully prevent them from having that that AMI or whatever has brought them into hospital. Oh yeah.
And just you also touched on Aboriginals, the Aboriginal heritage, Indigenous heritage. Our total population had about 1% of the cohort being Indigenous heritage. So it's certainly not an overrepresentation. So only having 1% of our cohort being of Indigenous heritage and still finding 28% of our probable definite FH group is of Indigenous heritage is certainly not because of a bias like overrepresentation.
course.
Thank you. Hi, excellent presentation. My question is also around the selection bias. You mentioned that among the 12,000 patients you had in your cohort, half of them are excluded. Did you do any like descriptive analysis between the groups who were excluded versus who were included? And if you did, was there any difference by like socio-demographic characteristics or any other characteristics that you can name? Thank you.
Take that. Or do you want me to?
Do you know the answer to that?
So we couldn't actually compare the two because we don't have that LDLC data for the patients that we took out of the cohort. We can't even determine their likelihood of having FH. So the reason we excluded them was not because we had missing data or just some of it was missing, is because we didn't have the necessary data to actually properly phenotypically diagnose these patients.
Okay, I understand, but yeah.
So it's a good question, and the answer is no, we didn't do, I think what you're asking, and we should do it, and we will do it, is looking across the 6,000 we used and the 6,000 we didn't use and see if there's a difference in age and gender and things between those two groups.
Exactly.
And we can add that as, I guess, like an appendix on the paper that we're eventually going to publish on this work. But no, we haven't done it yet, and it's a really good point you've raised, and we should do it. Yeah.
Thank you.
Just working. Thank you. That was a great presentation. Is there any genetic data in Indigenous populations to support what you're finding in this cohort?
Nothing published. So there are some researchers who are sort of working in this space and may have some data on this yet, but we don't know yet. It hasn't been published. So for Australian Indigenous populations, we don't have a baseline rate of proportion of FH in that community. Our study is indicating that it's quite high, but we can't necessarily differentiate definitively whether those people are more kind of metabolic syndrome and have high cholesterol for those sorts of reasons, or whether it's a true genetic FH, because we're just using like a phenotypic diagnosis. So it would be really interesting to see the genetic data and kind of compare it with that and try and get a clearer picture. Hopefully something comes out someday.
Very nice presentation, thank you. Sorry if I missed it, but how did you determine the likelihood of FH? And in this population, the LDL HDL ratio, how does it look like compared to just classic hypercholesterolemia?
Might pass to you.
So the way we phenotypically diagnosed FH in our paper is, so the Dutch Lipid Clinic Network score has several factors that give points to certain things. Unfortunately, most of that is, or a lot of that is about physical examinations, which we had no data on. So what we did use from that is the age at first event and their LDL-C levels. Yeah.
So basically, I can't remember the specific numbers, but there are LDL cholesterol levels at a certain point will give you a certain number of points towards your Dutch Lipid Clinic Network score. So if you sort of have to reach a certain threshold before you become probable FH, and then if you go over another threshold, you become definite FH. So primarily we were driven by the cholesterol levels, although you do get a couple of points on that score if you have your cardiac event before age 55, I believe, for men. Yeah, that's right. And there are other criteria you can use for that scoring, like the presence of the cornea Sarkies, like I was showing with the Mona Lisa, and a few other kind of clinical and family history things, but we didn't have access to any of that. So we were kind of going just based off what we had. So we feel we're underestimating it, even though we got a higher, like over 2% of that population in the kind of definite FH category.
I just have a great presentation, and I just have a question. So you did come, like, from your results, you have this 2%. Is this going to then be given to the doctors and possibly the patients so that they are aware that they might have this and so that they could go for the testing? Or
I wish, but it's we got de-identified data, so we can't re-identify it, and this is a historical cohort study as well. So I don't know that we have the ability to go back and re-identify those people and actively contact them. What we're proposing is this kind of gives us a good evidence base to do screening prospectively in this population and identify them as they're coming into the hospital rather than retrospectively. But we could ask David whether that is actually possible to do, to re-identify people and notify them. Yeah.
I stop there. Do we have questions? No. Right. And yeah, we can always communicate more during the networking time. Yeah. Thank you. Thank you, Rachel. Thank you. Shawon, he's here definitely. All right, so Dr. Shawon is a medically trained early career epidemiologist working at the Center for Big Data Research in Health at UNSW. He's building an independent body of large-scale population-based research projects to generate real-world evidence about the effectiveness and outcomes of cardiovascular care and to inform improvements in healthcare and quality of life for Australian and global populations. He completed a doctorate in population health from the University of Oxford and Master of Science in Epidemiology from the Karolinska Institute, Sweden. He has conducted research for more than 12 years on various chronic diseases using linked to routine electronic healthcare data. Let's welcome Dr. Shawon.
You should go first. Okay. Sorry, I actually lost my way coming up. Took the other lift. Thank you. Thank you, Phoebe, for your excellent introduction. So I've got a long name. Just call me Shawon, although it's my last name. But yeah, we're not going there. And I'm coming from the Center for Big Data Research in Health from UNSW. And today I'll be talking about CIED infection, which stands for cardiac implantable electronic devices. So we'll be looking at the risk of this complication among patients who had the CIED devices installed. We'll be also looking at the risk factors, and then also we'll touch upon the clinical management of these patients. So we all have our hearts beating regularly, rhythmically. What happens if it doesn't? We put electronic devices that help to set the rhythm to normal, and these are called CIEDs, and most common one is pacemaker. We've also got defibrillators, and then there are more complex devices like CRT devices. And with time, the use of these CIED devices is actually increasing in Australia and also worldwide, mainly because of early diagnosis and also with aging population, because conditions like atrial fibrillation actually increases with age. So as the use of CIEDs are increasing, so does the complication. And one of the most important complications of these devices is having an infection. And as you can understand, this is an infection that's actually very close to your heart. So this is really dangerous. And we wanted to look at what's going on in terms of looking at the real world data from Australia and try to identify several things. So this presentation is actually based upon the 3 works that I've been doing over the last couple of years, and all using linked administrative data from New South Wales. So we will be focusing on first on the incidence of these infections among patients who had the device installed. Then we'll be looking at the risk factors of having these infections, and then what is the impact of these infections on patient mortality. And then we'll be talking about clinical management, mostly around lead extractions, which is a guideline recommendation. We'll talk about that later. So in short, for all of these 3 studies, I used the linked administrative data from New South Wales. And these are New South Wales admitted patients data collection, or APDC. And then also we used linked mortality data. We identified patients who had CIED procedures between 2016 and 2022. And we did that by looking at the procedure codes, which is called ACHI codes. There are specific ACHI codes for CIED device installation. So we found those patients, and then we looked at the, we identified CIED infection by looking at their ICD-10 codes. There are specific ICD-10 codes for identifying these infections. And then we mainly did Cox proportional hazard regression. So the first finding is the rate of infection is actually quite low in this population, thankfully. So within 1 year of CIED device installation, there is only 1.1% of patients who had these infections. And most of these infections actually happen quite early. So within the first month, as you can see in the first bar chart, within the first month, the infection rate is quite high. And then with time, it subsides. And when we also looked at beyond 1 year, the infection rate is actually quite low. The risk of these infections is actually quite high among patients who had a complex procedure. You can see the CRT or cardiac resynchronization therapy devices are quite complex, and they have more leads going into the heart chambers. So that's why, as you can see, the infection rate for them is quite higher than the pacemaker ones. So we also looked at patients who had revisions or replacement compared to a de novo installation, and we found that those patients who had revision or reinstallation also had a higher risk. Then we looked at patient characteristics and how it can affect the risk of infection. And as you can see, younger patients are more likely to get these infections than older patients. And I think this is one of the few incidences in cardiovascular research where younger population younger population has a higher risk than the older population, because everywhere it just goes with age. Obviously, we found that patients who had 2 or more CIED procedures done before, which means they had replacement and revision, they had higher risk. Also, as mentioned earlier, CRT devices were more likely to have a higher infection rate. But the most important and significant and strongest risk factor was if someone had a prior CIED infection, and it just jumps the adjusted hazard ratio to 12, which is very high. And this is actually important also to identify these patients and then do something probably different, which I will talk later. We also looked at patient morbidities, comorbidities, and how that can affect their risk of infection. And as you can see, so these are only the conditions with significant results. So those with CKD, cardiomyopathy, COPD, atrial fibrillation, and concomitant cardiac surgery, they all had higher risk than their counterparts. So the last one, the concomitant cardiac surgery, I think it's reasonable, because these are the patients who had probably was having a valve replacement, and at the same time, a pacemaker was also put into them. And since it actually needed more procedural time, there is more risk of infection involved. So now we will be looking at, if someone had an infection, how bad it is in terms of mortality. And as you can see from the very start, so this is a Kaplan-Meier plot comparing 2 groups. One group had no infection, the other group had infection. And as you can see, by 1 year, almost 1 in 5 of these patients died, those who had infection, compared to the other group who had only 7% of them died. And if we convert this to adjusted hazard ratio, it's 2.73 times more likely to die than those who did not have infection. Over the time of the follow-up, the difference actually converges, but still they carry a higher risk over 5 years of follow-up. And as you can see, it also converted to a hazard ratio of 1.83. So still, it's almost 2 times more likely to die. So now, all the current guidelines and cardiac society statements underline that in patients who had an infection, the grade 1 recommendation is to remove their lead from the heart chamber. So that's lead extraction. And in spite of this strong guideline recommendation, we found that only 24% of those patients who had a CID infection actually had a removal within 30 days. And among those who had a lead extraction, it was quite quickly. It was within 1 day, median time, of having this CID infection diagnosed. We then looked at what are the factors that actually contributed or that actually affect the likelihood of getting the lead extraction. So as you can see, females are less likely to get this lead extraction. Same for older population and those with chronic kidney disease. On the other hand, we could see those who had also an endocarditis diagnosis along with the CID infection, or a code for Staphylococcus aureus infection or sepsis, they are more likely to get removed. And also a patient who had a revision or replacement procedure compared to a de novo installation were more likely to get their lead extracted. And the last thing we looked at is the rate among private versus public hospitals, and those patients who were treated in private hospital were more likely to get their lead extracted than public hospitals. So there is an inequity angle here as well. So since we know that these are all guideline recommendations, we also try to look at, okay, what's actually going on in real world in terms of patients who had their lead extracted versus who did not. As you can see, we found a difference, and from the Kaplan-Meier plot, those who had a removal in green line, they had a lower risk of mortality over the 1 year of follow-up. And then when we compared that with our regression, actually, I can't see the numbers here. So as you can see, compared to those who had no extraction, those who had early extraction, and we defined early as within 7 days of their infection diagnosed, they were less likely to die. Those who had a late extraction from 8 days to 30 days, they're also less likely to die. But I think we can't say definitely whether early extraction is better, but we could not differentiate because the confidence intervals are overlapping here. So we cannot differentiate the difference here. But in general, lead extraction saves lives. We also looked at subgroup analysis to find out which patients are actually more likely to get a better survival probability among those who are extracted. And as you can see, patients with sepsis, they had strongest mortality reduction if they're from lead extraction. However, in women and in older age people, we did not find the benefit was a bit lower than at the other groups. And then across all the other characteristics, we did not find any significant heterogeneity in the impact. So what does all of this make sense? So it says we need, so now we've got evidence, but then we also need to improve the practice. And we, by doing something, the first thing we need to do is from the analysis where we looked at the risk factors of CID infection, we could now identify those patients who had higher risk, and we could treat them differently. For example, we could put them, clinically speaking, we could put them antibacterial envelope that is recently in the market, or we could probably put them into leadless pacemaker. So there is no lead within their heart chamber. So that sort of patient profiling and then treatment should be done. The other thing we really need to focus on is timely lead extraction. The rates are quite low when we compare this with countries like US. Actually, in the US, the rate of lead extraction is lower than ours, but still, I think we need to do a lot in that space. And I think that's my last slide. So yeah, thank you for listening.
Thank you, Dr. Shawon. Any questions from the audience?
Thanks for the good presentation. I actually have two questions. My first question is, how does the sort of rates of infection, you said it's really low here in Australia or in New South Wales, how does that compare to, say, other states and other countries around the world?
Okay. I can't speak of other states within Australia because they haven't done analysis of these population-based studies. There are a few hospital-based studies, but the rates was slightly higher. The other issue is there is no contemporary data on that. So ours is quite contemporary from 2016 to 2022. But there are some studies from Queensland and also from Melbourne, and they were back in days. And I think with time, the clinical management of these patients are improving, so that can also play a role. In terms of comparing it with international evidence, I think we're still doing better than other countries, especially if we compare that with US data. So, yeah.
Okay, that's good to know. And my second question is, why do you think younger people are at a higher risk of getting this infection?
That is a really good question. And I also scratched my head around like what's going on. And interestingly, I first thought that, okay, probably it's something that there's like a selection bias that we could not explain between these two groups. And then we found that even in previous literature, they also found that, and also in the clinical trial data, patient younger age actually had a higher risk. And one of, I really don't know, and there's no exact answer to that. Some of the hypotheses, which I've read in the existing literature, is most probably these patients are more active and they go out right after the surgery or something. So their lifestyle could probably have an impact, but these are like only hypotheses and without any evidence.
Thank you.
Hi, great presentation.
Thank you.
I've got a question around you. So you touched on a little bit about adherence to guidelines. So I was just wondering, how would you envisage, I guess, increasing adherence to guidelines? Can you talk a little bit more about that? Is there some sort of like benchmarking that happens and, these type of data are fed back to clinicians so that they can change, I guess, practice when it comes to lead extraction?
That's a really good question. And so when we also have practicing cardiologists in our team, and when we talk to them, and also we looked at the literature, one of the main reasons for having low adherence to lead extraction is many patients and also some clinicians think that it's a high-risk procedure. And that can sometimes deter people not to go into that route, and then probably they were given long-term antibiotics and stuff. So the first thing, and there is a recent European study where they looked at interventional cardiologists and electrophysicians and their understanding about this procedure. And it was also shown there, like many people consider it as a high-risk procedure. I think we need proper education around that. That look, yes, there is always a risk involved with the procedure, especially if you're removing something from the heart chamber. But this also saves life. And the other thing is, I think we need to improve the referral system because these procedures are not done in every hospital. So there should be early identification and then referral, and that also involves a team approach.
Thank you. Thanks for the presentation. And I definitely see a lot of, from my clinical experience, see a lot of infection for the pacemaker. And I just want to check, like with your sample, you mentioned about the antibiotics pocket with probably the Tyrex. Is that your sample including those patients already had the antibacterial pocket? Was that part of the sample as well?
We could not identify that, unfortunately. And it's less likely, I think, I don't know the exact date when it was in Australian market, but even if they have that antibacterial envelope, that the number would be quite low. Because it's quite expensive, actually, to put that antibiotic sleeve, and yeah.
Thank you, everyone. Due to time limit, we have to move to the next one. So thank you, Dr.
Thank you.
Shawon. Next, let's welcome Dr. Emma Zhao. So Dr. Emma Zhao is a clinical nurse specialist at the Royal Prince Alfred Hospital Pain Management Centre and a PhD graduate from the University of Sydney. Her research focuses on cognitive impairment in cardiac patients and chronic pain management. So Emma has published in peer-reviewed journals and presented at national and international conference. She integrates clinical expertise with research to improve patient care, and her contributions have been recognized with awards including the CSANZ Cardiovascular Nursing Council Rising Star Award. Emma is actively involved in clinical education, research leadership, and developing innovative patient-centered care models. Well, let's welcome Emma.
Thank you. Thanks for the opportunity. From the bio, you probably think it's quite strange. I'm a cardiac nurse and now working in the chronic pain area. So I kind of just moved towards to the chronic pain research while I was doing my PhD in cardiac, like cognition in cardiac patients. And that actually raised my topic today about how I want to demonstrate the overlap between chronic pain, cardiovascular disease, and cognitive impairment. And how, like, I want to do some kind of a proposal later on this year to do the research in this area. So I wouldn't have much data to share today, but more about what I have found so far in the clinical and research experience. So let's talk about the cognitive impairment and cardiovascular disease. I think heart and brain are actually have some there is an interdependency between heart and brain because they often cognitive impairment and cardiovascular disease often coexist. Maybe because due to their relationship about the blood perfusion, inflammatory response, and oxidative stress. And brain is also considered as one of the vascular organ, which require 15 to 25% of the cardiac output. They probably use the cardiac output for like cerebral blood flow or brain function or integrity structures. And from what my study what I did before with the patients in ACS population, what we found is like 4 weeks after ACS post-discharge, there was around like 30% of patients have cognitive impairment. And whereas even after 3 months after discharge, there is still around 11 to 52% of them have cognitive impairment. So which means like after this big cardiac events of those patients, while they are trying to adapting the new lifestyle or learning their medication and follow their cardiologist's instruction, they are kind of struggling to understand or hear all these instructions because of their cognitive functions. And then let's bring the attention to bring the chronic pain into the big picture. So chronic pain is actually quite common in Australia. It's over 3.4 million of Australians have chronic pain, which means 1 in 8 of us will have some types of chronic pain. And some study has shows that chronic pain can increase the cardio risk factors. And we can see from the recent existing the cardiac risk factors calculator, chronic pain is not part of the tool yet. One of the calculation is not part of the risk factors in the calculator, which is fair enough because there is not many evidence has been existed so far. But from what I found in the current existing literature is some of the study use a big data set. One of them is a UK Biobank. And what they found, and that paper has published in the European Journal Prevention Cardiology, what they found is like when patients have a chronic widespread pain, it would increase their risk of cardiovascular risk mortality to 46% higher. And from the Framingham big data set in US, and they showed that patient with chronic pain will increase 29% of the risk of stroke. And then I looked into where I worked at RPAH Pain Management Center, and we have the big data set called EPOC, which is national recognized data set that has been used by New South Wales Health for the last 10 years. And we did some preliminary data analysis, and what we found is pain interference actually associated with heart circulation conditions. That kind of just raising to my attention. So before I move on to the next topic, and I just want to give you a bit of brief idea of what is the pain. So pain is like your body alarm system that warns you there is some potential problems with your body. So for example, when cardiac patient, they have a chest pain, that's an alarm system for them to go to the emergency or go to their GP or cardiologist, and that warns them they might have a heart attack or something like that. So International Association for the Study of Pain defined the pain as an unpleasant sensory and emotional experience that influenced by biological, psychological, and social factors. So which is quite different from what we understand the pain before is that your body just react to the pain and that was that. So what they think now is your pain can be impacted by biological factors such as inflammatory or autonomic system, or some psychological factors such as anxiety, depression, or kind of social factors such as your family history or your relationship or where you work or your the environment surround you. So that's actually quite different from what we know before. So in terms of the chronic pain, that means the pain is more than 3 months. And in chronic pain, the alarming system could ring louder or keep on ringing or even rings when it doesn't necessarily need to. This may because of the pain sensitization, which means your nerve system is very sensitive and constantly sending the signals to your brain, and that tells your brain there's something wrong with you. So from the picture, you can see that there is 2 ways. So in the past, they think the brain just sending the signals to your body that tells you have a brain. But nowadays, the research has shows that your pain, it's a mutual way. So the brain will send the signals to the body, and the body will keep on telling your brain that you might have something wrong within you, and also that might impact your attention or your focus or your memory difficulties and your decision making. So it's like what shows in this picture. Your spinal cord have what they saying with the neuroscience saying they have some there's a gating system in your spinal cord that when it has a pain signal, it will open up. So in chronic pain, a lot of the patient have this gating system opening all the time that keep on sending them signals. So you can imagine if one of the patients have a severe chronic pain disease and also have a cardiac disease, when their pain flares up, they might just can concentrate on whatever the cardiologist tell them to do or what medication they're going to take or making some healthy decisions or go for exercise because they are too distracted. So just to summarize what we know so far, so we know that there is an overlap between chronic pain, cardiovascular disease, and cognitive impairment, but the evidence are very limited so far. And there's some risk factors like biological risk factors and psychological and behavioral risk factors, as well as the cognitive risk factors, same as well as the health literacy can play a part into that. So our current knowledge gap is chronic pain is not really being paid attention by either pain clinic or cardiologist, and no one really gonna take your blood pressure in the pain clinic, and cardiologist not gonna take the chronic pain into their assessment as well. So those patients probably not gonna be recognized in the clinical setting. So as a clinician as well as a researcher, so what I propose to have now is, don't know what's happened. Oh, yeah, we got it here. So my research proposal is to establish the title is to establish a chronic pain as a cardio risk factors by using a multi-method study. So the aim is, first of all, to quantify the prevalence and the association between chronic pain and cardiovascular disease, which means we want to figure out how big the problem is and how can we measure this problem in a measurable way. And the other aim is to explore the patient experience and to find their perspective for the early intervention and screening, probably in the clinical setting in pain clinics, as well as probably in cardiac rehab in the future. So for the first part of the study, what we want to do is a prospective 12 months observational study that just to collect the patients from the adults who have a chronic pain over 3 months time. And then because this is a very pilot, first time study, we just collected through the Sydney Local Health District at RPAH Hospital and its affiliates, probably it's the Concord Pain Clinic. And we want to collect the various of data. For the pain, we want to collect their use the pain, brief pain inventory questionnaire, which to assess their pain interference and severity. And we also want to collect the data for the cardiovascular indicators such as blood pressure, cholesterol, and their heart rate variability, which can be measured with the wearable monitors. And obviously, we're going to collect some assess their cognitions by using Montreal Cognitive Assessment Tool. And we also think physical activities and health literacy and their mental health are very important. So that will be also part of the assessment by using the questionnaires and wearable monitors. Followed by the first study, and we will do a follow-up patient-centered study. So that will be using a mixed method, mixed study method, and that to collect some patient-reported data. So it will be two parts. The first part will be the qualitative data by using individual interview or focus group, just to explore their perspective of cardiovascular risk, how much they understand it, and what do they think is the barriers of screening at this stage of their life. And we will also use some patient survey just to see some quantified patient data as well. So I think based on after we've done this study, we're hoping to have some better idea of the in the chronic pain population, what's the association between the cardiovascular disease, cognition, and chronic pain, what's the relationships looks like, and we're hoping to provide some recommendations. And one of them is to have some targeted screening access for the pain service as well as for the cardiac stuff. And we want to have some early patient to have an early referral to the cardiac rehab if they have a chronic pain. And also we want to combine those two services together and have some integrated prevention pathway for the patients in the future. And I think this study, just to mention, I think because there's not much data we can provide so far, I think this is quite a novelty study. From my understanding, there hasn't been much prospective study has reported so far. So I'm hoping that can give us more data and evidence for future research. And in terms of the next steps, I think we're just gonna try to get some ethics approval and start the data collection. And hopefully we can, using the EPOC data I mentioned so far, and also because as I mentioned, EPOC has been used by New South Wales House for the last 10 years, but the license probably going to be expired very soon. So we probably will move on to some other data set, but we want to integrate that data set into our research, and then we can use that in the future. Thank you.
We might just take 2 quick questions.
Thank you for excellent presentation. Quite an interesting idea and also an ambitious study. My question is around, so in AIM-1, you mentioned that you will be collecting samples. So will it be consecutive patients, or will you follow any sampling methods like systematic random sampling or anything?
So this is still a proposal. But I think we're gonna collect the data from the baseline, and that's the general practice for, like a usual practice for the pain clinic. And we normally collect the patient's baseline data, and then we'll follow them up in the 3 months and 6 months and 12 months time, and just to see if there is any changes, and hopefully to see if there any intervention in the pain clinic may impact their outcome as well.
Because my next question is also related. From AIM-1 to AIM-2,
Yes.
there is also a mention of selected participants, and do you have any idea like how do you select those patients?
So I think that will be similar to what I did in my previous study, that we just use those baseline patient sample, and then and at the end of the baseline data collection, we will give the patients another participant information sheets and see if they want to give us some feedback or share their experience. So for those who meet the criteria, and they can either join the focus group or one-on-one interview based on their availability, and then we will do a qualitative data analysis. And for the survey, that will be normally sent out by the REDCap or so electronic kind of link that give to the patients to collect some data.
Yeah, my question is around, because they are all linked in collecting, and there might be a selection bias in the whole thing. So just, yeah, a thought. Thank you.
Thank you. Do we have any question on Zoom? No? No. Okay.
Thank you. Nice presentation. Stress is known to activate SNS and contribute to cardiovascular diseases. And I'm assuming that patient with chronic pain will be quite stressed.
Yes.
Are you planning to measure cortisol level, for example, in your patient sample, or to measure, biologically speaking, the level of stress?
For this proposal, I don't think I will measure the biological risk factors. It's probably, we will just use a questionnaire to collect their anxiety and stress level based on the DAS21 as well as other risk factors. In terms of the biological risk factors, I think that will be something we need a more collaborative kind of research that need to be done in the future. But with no fundings or anything, I don't think that's something I can do at the moment. Yeah.
Okay, thank you. Thank you, Emma. All right, we're going to wrap up the seminar. Before we finish, I just want to say to everyone, thank you for coming today and or joining from the Zoom. We're going to have another seminar in July, so feel free to register and come back, and we have more discussion on that. And also we have a survey. If you can scan that code and give us some feedback for today's seminar, that would be greatly appreciated. Finally, we're going to give the certificate to all our speakers today and have a photo together.